joint capsule and supraspinatus tendon. The glenoid labrum is intracapsular. The joint capsule is most lax on the superior aspect of the joint. The joint cavity normally communicates with the subacromial bursa. Joints of the shoulder complex are glenohumeral, acromioclavicular, sternoclavicular, and scapulothoracic. Here, the shoulder joint is mainly the glenohumeral joint. It's a ball and socket type of synovial joint between rounded head of humerus and shallow pear-shaped glenoid cavity of scapula. The articular surface is covered by hyaline articular cartilage, and the glenoid cavity is deepened by the glenoid labrum. Capsule, it encircles entire glenohumeral joint. The attachment medially about to the circumference of glenoid cavity beyond the glenoid ligament, and laterally below to the anatomical neck of the humerus. The capsule is thick above and loose and lax below. Ligaments. The ligamentous stability is by glenohumeral ligaments, providing anterior reinforcement, coracohumeral ligaments, providing superior reinforcement, and coracoacromial ligament, providing superior reinforcement. Now coming to the bursa, there are mainly three bursas: subacromial bursa, subscapularis bursa, and infraspinatus bursa. Subscapular bursa, it intervenes between the tendon of subscapularis and fibrous capsule, communicates with the joint cavity through oval gap between superior and middle glenohumeral ligaments. Infraspinatus bursa communicates with the joint from behind. Subacromial bursa, it's the largest bursa of the body, intervenes between supraspinatus and coracoacromial arch. It does not communicate with the joint. It is of great value in the abduction of arm at the shoulder joint, where it protects the supraspinatus tendon against friction with the acromion. Glenoid labrum, it's a fibrocartilaginous ring, triangular in cross section, attached to the peripheral margin of glenoid cavity except above, deepens the glenoid fossa. So coming back to the question, which is the correct answer? Can anybody answer the question? Okay, the answer is B. Next question. The shoulder joint is superiorly not related to. The options are supraspinatus, axillary nerve, subacromial bursa, and coracoacromial ligament. So the relations of the shoulder joint: superiorly, there is supraspinatus muscle, subacromial bursa, coracoacromial ligament, and deltoid. Inferiorly, there is long head of triceps brachii, axillary nerve, and posterior circumflex humeral vessels. Anteriorly, there is subscapularis, coracobrachialis, short head of biceps, and deltoid. Posteriorly, there is infraspinatus, teres minor, and deltoid. So coming back to the question, shoulder joint is superiorly not related to. The answer is B, axillary nerve. That is an inferior relation. Muscles of shoulder. The main muscles are supraspinatus, infraspinatus, teres minor, and deltoid. Supraspinatus, the origin, the medial two-third of supraspinous fossa, insertion to the greater tuberosity of humerus. Action is shoulder abduction and dynamic stability. Innervation is by suprascapular nerve. Next is the infraspinatus. Origin, medial two-third of infraspinous fossa, insertion into greater tuberosity. Action is shoulder external rotation plus dynamic stability, and innervation is by suprascapular nerve. Teres minor, origin, upper two-third lateral border of scalp, insertion to greater tuberosity. Action is shoulder external rotation, adduction, and dynamic stability. Innervation is by axillary nerve. Next is the deltoid. Origin, lateral one-third of clavicle, acromion process plus spine of scapula. Insertion is deltoid tuberosity. Action, shoulder abduction, and innervation is by axillary nerve. So these are the other muscles at the shoulder that helps movement in shoulder joint at shoulder joint. Trapezius, levator scapulae, rhomboid minor, rhomboid major, pectoralis major, pectoralis minor, teres major, subscapularis, triceps, and biceps. Serratus anterior. So, which muscle is the initiator of arm abduction? The options are deltoid, trapezius, supraspinatus, serratus anterior. Does anybody know the answer?
Supraspinatus.
Supraspinatus.
Yes, that's correct answer. So, movements at shoulder joint, there is flexion, extension, internal rotation, external rotation, adduction, abduction, and circumduction. Flexion, it is 0 to 90 degree, mainly by pectoralis major and deltoid. That is the anterior portion. Extension, 0 to 45 degrees by teres major, latissimus dorsi, and deltoid. Internal rotation, 0 to 40 degrees by pectoralis major, latissimus dorsi, teres major, deltoid, and subscapularis. External rotation, 0 to 55 degrees by infraspinatus, teres minor, and deltoid. Adduction, 0 to 45 degrees by pectoralis minor, latissimus dorsi. And adduction, 0 to 180 degree by supraspinatus, that is the first 0 to 15 degrees, deltoid 15 to 90, and trapezius and serratus anterior more than 90. Circumduction, it is a combination of flexion, abduction, extension, and adduction, or in the reversed sequence. Which of the following is not a part of rotator cuff? Teres minor, teres major, supraspinatus, infraspinatus. Can anybody answer?
Teres major.
Yeah, that's true. Rotator cuff. It's a group of 4 muscles that originates at the scapula and inserts onto the humeral head. The mnemonic is SITS, S for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapularis. The rotator cuff helps to stabilize the humeral head in the glenoid fossa. It also helps in shoulder rotation. This is the line of action of 4 segments of the rotator cuff. Glenohumeral stability, there are 2 types of restraints, that is the static restraints and dynamic restraints. Static restraint is provided by the glenohumeral ligaments, glenoid labrum, articular congruity and version, negative intra-articular pressure. And the dynamic restraint is provided by the rotator cuff muscles, rotator interval, biceps long head, and pediscapular muscles. Coming to the blood supply of the shoulder joint, it is provided by the anterior circumflex humeral vessels, the posterior circumflex humeral vessels, suprascapular and subscapular vessels. Nerve supply is by axillary nerve, suprascapular nerve, and musculocutaneous nerve. Thank you.
Hello. Hello, Anjana.
Sir.
Yeah. Yeah, I joined via Luminous mode. I have some technical issues. Actually, I was not able to listen to half of your presentation. Those things that I listened to, I think you have covered the anathema pentax shoulder joint and also the some important question that used to come regularly for the exams. Okay. I don't have anything more to add. Venu sir, ഉണ്ടോ? I think sir is not available. We'll go to part B, the second part of presentation. Part B ആരാ നാദിയല്ലേ?
Sir, screen visible on, sir. Hello? Ade. Good morning. Today my topic is shoulder dislocation and rotator cuff injury if I can make part B. Coming to scenario, a 35-year-old male patient presented in ED with alleged history of injury while playing basketball when a friend hit his throwing arm. He complains of pain in the right shoulder and holding his arm internally rotated and abducted. Questions are: what kind of injury do you suspect in this patient? This is the X-ray of the patient. And what is the next step in your management? What advice would you give to this patient on disposition? This is the first question. Second scenario is a 60-year-old male presented in ED with complaints of bilateral shoulder pain, right worse than the left. He works at a grocery store and this involves significant lifting and reaching overhead. Pain is of dull aching type which increases during night and disturbs his sleep. What's your probable diagnosis? List a few conditions which can precipitate these kind of injuries. Apart from physical examination, what imaging will help you in diagnosis? What are your treatment options for this patient? So I'm sorry if there's any mistake in the questions because I really didn't get a source to find the question, so I made up these questions like 10 minutes ago. So coming to the theory part, shoulder dislocation. Shoulder joint is the body's most mobile joint. Its advantage is that it can turn into any direction, but this also makes it an easy joint to dislocate. The shoulder joint is more prone to dislocation due to the laxity of capsule as well as the disproportionate articular surface. As Anjana had mentioned earlier, there is a shallow glenoid cavity and it only articulates with a small part of the head of humerus. It's one of the most commonly dislocated joints, and the dislocation can either be anterior, posterior, inferior, or anterior-inferior. Most common cause of shoulder dislocations are sports injuries, any hard blow to the shoulder or motor vehicle collisions, or any fall on outstretched hands. Coming to the types of dislocations, the most common one is anterior dislocation, which accounts up to 97% of the shoulder dislocations. It's usually associated with isolated traumatic incident, as in a blow to abducted and extended hand or a fall on outstretched hand. So in anterior dislocation, during the abduction, the head of humerus is pressing against the lower unsupported part of the capsular ligament. There are different types of anterior dislocation. It can either be subcoracoid, subglenoid, subclavicular, and in extreme rare cases, it can even be intrathoracic and retroperitoneal. So almost all anterior dislocations are initially subglenoid, which might convert later into subcoracoid or subclavicular. So on examination, the hand is in an abducted and externally rotated position, and the acromion appears prominent. In case of anterior dislocation, The associated injuries are there can be axillary nerve injury, which can cause the paralysis of deltoid, which in turn results in the loss of the rounded contour of the shoulder. As you can see in the picture, the left shoulder is maintaining the rounded contour, whereas it is lost in the right shoulder. It can also cause a subscapular or radial nerve injury, also axillary artery injury. This is the radiograph showing anterior dislocation. There is a widening of gap in the uh, um, shoulder, the cavity. The next is posterior dislocation. It's rare type. It occurs only up to 2 to 4%. It's most typically due to violent muscle contraction from electric shock or seizures. On examination, hand is held in abduction and internally rotated. And as you can see in the picture, the anterior shoulder is flattened with a prominent coracoid process. This is the X-ray showing the posterior dislocation. There is widening in the glenohumeral joint space, and this sign, as you can see, it is known as light bulb sign. It resembles a light bulb in X-ray. Posterior dislocation has a higher risk of associated injuries, where you can have a fracture of surgical neck of humerus or a tuberosity. There can also be injuries to labrum or the rotator cuff. In elderly patients, or if the patient is unconscious following a trauma, the posterior dislocation might go unnoticed in some people. Next is inferior dislocation. It is a very rare type of dislocation, amounts to only 1%, also known as luxasia recta. It's usually caused by hyperabduction or with any axial loading on abducted arm. So the patient posture will be, the arm will be held above and behind the head, and the patient will be unable to adduct the arm. It's often associated with nerve injury, rotator cuff injury, any tears in the internal capsule, and inferior dislocation also has the highest incidence of axillary nerve and artery injury. This is the radiographic image of inferior dislocation. This is the patient position. This will be the patient position in inferior dislocation. In all of shoulder dislocation, according to history, the patient might give a popping sensation in the shoulder. There will be a sudden onset of pain with decreased range of movements, and patient might complain of a sensation of joint rolling out of the socket. And there might be history of past shoulder dislocation, because if the shoulder is once dislocated, it becomes highly unstable and there is chance of recurrent dislocations. And you have to see for neurovascular compromise, axillary nerve innervates deltoid and teres minor, and it provides sensation to the lateral aspect of the shoulder. So during examination, this should also be kept in mind. Complications of shoulder dislocation, there, as I've mentioned earlier, there can be fractures of surgical neck and tuberosity. And Bunkart's lesion is a common complication. It is the injury to the inferior glenoid labrum due to anterior dislocation. So if there is only soft tissue injury, it is known as soft Bunkart lesion. If there is any fracture or bony fragment involvement, it is known as bony Bunkart lesion. So this above image shows a bony Bunkart lesion, where it is a superior view where you can see the anterior dislocation and there is fragmentation of bone. So along with the soft tissue injury, there is bony fragment involvement. So this is a bony Bunkart lesion. Another complication is Hill-Sachs deformity, wherein in anterior dislocation, there is a compression fracture of the posterolateral humeral head. As you can see, there is anterior dislocation and this posterolateral aspect of the humeral head is fractured. So this is Hill-Sachs deformity. The next is reverse Hill-Sachs deformity, where there is an impaction fracture of anteromedial aspect of humeral head. It is seen in posterior dislocation. Let's say this is the superior view. So there is a posterior dislocation of the humeral head and it causes a impaction fracture in the anteromedial aspect of the head of humerus. So the management of shoulder dislocation is most commonly done as reduction with conscious sedation using fentanyl, ketamine or etomidate, or You can also give an intra-articular injection of lidocaine for pain management. The common methods of reduction are traction, counter-traction method, external rotation, Milch technique, Fair, Spasso, and Stimson's method. And there are certain contraindication to reduction of dislocation in ED. So if there is any humeral neck fractures, it can lead to avascular necrosis. So you can't initially reduce in the ED. Also, you have to avoid multiple attempts in injuries that include any neurovascular compromise. If there is any suspected arterial injury, you have to get an angiography first to confirm that. And if the patient is presenting in ED with a delayed presentation, like after 6 weeks, you should not attempt reducing in the ED. And if there is any multi-part or a shaft of humerus fracture also, you have to take it into the OT and then do the reduction. So next topic is rotator cuff injury. We know that we have learned it earlier that rotator cuff is a group of 4 distinct muscles and their tendons which provide strength and stability during the motion of shoulder complex. It includes supraspinatus, infraspinatus, subscapularis and teres minor. So it can present in 3 ways. It can either be tendonitis or bursitis or a rotator cuff tear. Tendonitis is when a single tendon is inflamed, which causing the pain only during specific movements. So if this inflammation of a tendon is spreading towards the bursa, then it is known as bursitis. So when a tendon is weakened due to the inflammation, if repeated injury happens to the tendon, it can cause the tear, causing the rotator cuff tear. The most common cause of rotator cuff injuries are pushing off with your arms, as in elderly patients, elderly people with arthritis and all, they'll have difficulty in getting up from chair. So they always push uh, push off with their arms when they are getting up from the chair. So this causes constant irritation in the shoulder rotator cuff tendons and can cause rotator cuff injuries, or any constant reaching, as in if you do continuous push-ups, or if you're playing basketball and swimming, or if construction workers or painters who have to constantly reach up with their arms, can cause rotator cuff injuries. Also, in sports like any tennis or any racket sports where you have to, there is forceful abrupt overhead movements, the already weakened tendons can undergo uh, tear or rupture. So in rotator cuff injuries, on examination, the patient will give history of pain while lifting hands or reaching out for things. And there is restriction in the range of movements. And he gives history of a dull aching pain which increases during the night. Diagnosis is through physical examination. You can use the help of USG as well as MRI. Also, management is with conservative management with his NSAIDs, and you can give a subacromial corticosteroid injection to reduce the inflammation. Physiotherapy also helps. If there is any rotator cuff tears, you can go ahead with surgical repair. So, coming back to the scenarios, the first scenario is a 35-year-old male patient presented in ED with history of injury while playing basketball. So, what kind of injury do you suspect in this patient? Can anyone answer? Hello?
Angle dislocation.
Okay. Yeah, anterior dislocation. And the next step of management, uh, can go ahead with reduction. And on this position, while discharging the patient, you can advise him to, you can provide him with a shoulder immobilizer or a sling, and you can advise for physiotherapy. Next scenario, uh, what is your probable diagnosis? Okay, right. this is a rotator cuff injury and other condition which can precipitate these kind of injuries. Like I said, if patient is athletes as in constant swimming or gymnastics or other hiking, if they'll have history, they can have rotator cuff injuries. And imaging, you can use an ultrasound or an MRI to diagnose. Treatment option, if there is no rotator cuff tear, you can go ahead with conservative management. If not, surgical repair has to be done. Thank you.
Hello, Nadia, നിങ്ങൾ പോയിന്റ്സ് എല്ലാം ഓൾ കവേർഡ് ആണ്. പിന്നെ ഇത് പ്രസന്റ് ചെയ്യുമ്പോൾ രണ്ടാളോടും അഞ്ജനോടും നാദിയനോടും എനിക്ക് ആദ്യം നമ്മളിപ്പോ റിവേഴ്സ് ഓർഡറിൽ വരുന്ന ഇതാണ്. ആദ്യം നമ്മൾ എന്താ വെച്ചാൽ വി ഗിവ് എ സെനാറിയോ, എന്നിട്ട് അതിന്റെ മുകളിലുള്ള ക്വസ്റ്റ്യൻ കൊടുക്കുക. എന്നിട്ട് പിന്നെ നമ്മൾ അതിന്റെ ഒരു ആൻസറിങ്ങിന്റെ ഇതിലേക്ക് പോവുക. അതായിരിക്കുമ്പോൾ കുറച്ചും കൂടി നന്നായിരിക്കും. അപ്പൊ നിങ്ങൾ തിരിച്ച് കംപ്ലീറ്റ് ഡിസ്കസ് ചെയ്ത് കഴിഞ്ഞ് പിന്നെ ഇതിലേക്ക് അങ്ങനെ പോകുന്നതിനേക്കാളും മറ്റേ രീതിയിലാണ് പോകേണ്ടത്. ആദ്യത്തെ പ്രസന്റേഷനിൽ പിക്ചേഴ്സ് എല്ലാം ഉണ്ട്, പക്ഷെ നമ്മളതൊന്ന് എക്സ്പ്ലെയിൻ ചെയ്ത് കൊടുക്കണം. ഇപ്പൊ നമ്മൾക്ക് മനസ്സിലായെങ്കിലും ഈ പിക്ചേഴ്സും സാധനങ്ങള് നമ്മള് റെഡ്യൂസ് ചെയ്യുന്ന രീതിയിലൊക്കെ കൃത്യമായിട്ട് പറഞ്ഞു കൊടുത്താലാണ് ബാക്കി കേൾക്കുന്ന ആളുകൾക്ക് അത് അതിനെ കൊണ്ട് ഗുണമുണ്ടാവുള്ളൂ. അതല്ലെങ്കിൽ അവർ ജസ്റ്റ് ക്ലാസ് കേട്ടിട്ട് അവരങ്ങ് എക്സിറ്റ് ചെയ്യും. അവർ ക്ലാസ് എടുക്കുന്ന രീതിയിൽ തന്നെ അത് ചെയ്താലാണ് നന്നാവുള്ളൂ. അതുപോലെ ഹൈലൈറ്റ് ചെയ്യേണ്ട കാര്യങ്ങൾ കുറച്ചും കൂടെ ഹൈലൈറ്റ് ചെയ്യാം. ഇങ്ങനെയുള്ള ഈ രീതിയിലേക്ക് ചെയ്താലാണ് നമ്മൾ എഫക്റ്റീവ് ആവുള്ളൂ. അതർവൈസ് ഇറ്റ് ഈസ് ഓക്കെ, വേറെ പ്രശ്നങ്ങളൊന്നുമില്ല. നിങ്ങൾ എങ്ങനെ ഈ സി ചെയ്യാൻ പോകുന്നത്? We are going to do C. വിനീത് വന്നിട്ടുണ്ടല്ലോ. ഓക്കെ, ശരി, യു കണ്ടിന്യൂ. I am just kidding.
Yeah, I was there. I couldn't join from my phone. That's why I joined from Jumina's phone. Nadia, can you just take your questions first? ഈ ക്വസ്റ്റ്യൻ ഹലോ ആദ്യ കേൾക്കുന്നില്ലേ? ഈ ക്വസ്റ്റ്യൻസ് യു ഹാവ് മേഡ് ഇറ്റ് അപ്പ് ബൈ യുവർ സെൽഫ് അല്ലേ? അല്ല the thing is, apart from part in the sense, you will be scenario and you will be asked 3 or 4 questions, and there will be a definite space. Whatever you write in that space will only be considered. That will be small of this. It's there. It's going by one sentence answer.
Audio clear. Audio.
Not clear, sir, still.
കേൾക്കുന്നുണ്ടോ ഇപ്പൊ? കേൾക്കുന്നില്ലേ?
Yes, sir. Okay.
അപ്പോൾ ഓക്കെ, thing is, FRCOM Part B exam answers they expect them to be very specific. അപ്പോൾ if they ask you to write one sentence answer in one sentence, then the second sentence, if you don't know the answer correctly, like if you are unsure about the answer, even if you write the second sentence, they won't consider that. If they want one reason for a particular thing, only the first reason will be considered. Second reason won't be considered for marking. Appo the questions and the answers to it will be very specific in FRCOM Part B. Appo though it is descriptive, it is not like we usually, it is not like something that we are very used to. If in a descriptive exam, if a question is asked, we used to write 5 sentence, 10 sentence, even if we know or don't know the answer. Either way, we might write 5 or 10 sentences. But in part B, we will have to specifically include all the points that they expect from us. Okay, about what kind of injury do you suspect in this patient? We'll have to, about not in this patient. This patient, you can definitely write anterior glenohumeral dislocation, അല്ലെങ്കിൽ anterior shoulder dislocation. If it is a question, if an ECG is shown, and if they ask what kind of injury it is, you will have to write acute coronary syndrome, which wall is involved. If the patient is STEMI or INSTEMI, it should include all parts, the complete answers. If only a part of the answer is written, they will give you only that much mark. Okay, the answers for part B is very specific. What is the next step in your management? Our next step is very tricky because the patient has come with pain. The pain relief might be the next step. If it is put by what you say, FRCOM, they might be expecting analgesia as your first answer. We described it as, or we thought it might be correcting the dislocation, but the first step after this might be pain relief or analgesia that they might have expected. In that way, the part B is very tricky, and unless you write that specific answer, they won't give you marks. What are the steps? You can write it down. First is analgesia, second is reduction, third is putting on sling and things like that. What is the next step? Next immediate step. But that might be putting a sling and pain relief, because reduction may be after pain relief. In that way, that should be very specific. And what advice?
Sir, one doubt.
Yeah.
Sir, what is the next step in your management? Next step മാത്രം പറഞ്ഞാൽ മതി. ആ series of steps പറയേണ്ട ആവശ്യമില്ല.
ഇല്ല, അവര് what are your next, what is your plan for this patient, അല്ലെങ്കിൽ what are your next steps എന്ന് ചോദിച്ചു കഴിഞ്ഞാൽ you will have to write steps. നെക്സ്റ്റ് സ്റ്റെപ്പ് എന്ന് ചോദിച്ചു കഴിഞ്ഞാൽ ഒരു സിംഗിൾ സ്റ്റെപ്പ് എഴുതിയാൽ മതി. that is the thing. ആക്ച്വലി ഇത് ഒരു എന്താ പറയാ, FRCOM-ന്റെ ഇതിന്ന് എടുത്ത ക്വസ്റ്റ്യൻസ് ആണെങ്കിൽ നമുക്ക് അത് കുറച്ചും കൂടി സ്പെസിഫിക് ആയിട്ട് അവർ ഇന്നതാണ് ഉദ്ദേശിക്കുന്നത് എന്നുള്ള we will be able to make out in a much more better fashion. ഇത് ആദ്യം ഇട്ട ക്വസ്റ്റ്യൻ ആയതുകൊണ്ട് ചിലപ്പോൾ ഒരു കുറച്ചൊരു ആംബിഗ്യൂറ്റി ഉണ്ടാവും. കാരണം she had put the questions by herself എന്നുള്ളതുകൊണ്ട്. ഓക്കെ, പക്ഷെ ഈവൻ ദെൻ നമ്മൾ FRCOM-ന്റെ എടുത്തു കഴിഞ്ഞാലും there might be questions where you won't be able to make out. പക്ഷെ generally they will be asking specifically what is the one reason, അല്ലെങ്കിൽ give two reasons. They will be asking specifically. Okay, what advice would you give to this patient on disposition? What all advices you should be giving? When should they what is their activity limitations? When should they review with orthopedics? What should be they doing after 3 weeks or 6 weeks? 3 or 4 points that should be specifically mentioned. Usually they will definitely ask what are the techniques. Mention 2 techniques or 3 techniques for correction. They will definitely ask. There are lot number of reduction techniques. There will be some 20-25 techniques for reduction shoulder dislocation, and also many modified techniques based on the classical procedures. You should at least know a few of them. As sir told, just mentioning them is not enough. You will have to know a bit more detail in that. At least ഒരു 10 എണ്ണെങ്കിലും അറിഞ്ഞിരിക്കണം. Tintinelli have, I think, 9 or 10 dislocation, correction methods, reduction methods. At least you should know them. Cockers, modified Cockers, Stimson, Parnola. There are quite a number of reduction techniques. you will have to know a bit of them. Okay, next scenario. Next is okay. 60-year-old male presented with bilateral shoulder pain, right versus and left. Significant pain is like. Okay. Nadia, I should say that your way of making up the questions and your making up the scenario and making up the questions are good. They are fairly the same way as MRCOM or FRCOM part B would be like. So if they ask what is your probable diagnosis, if you are not very much into it, if you haven't read that part, you will definitely have three or four diagnoses. If you're not very sure, if the history is not very very clear to you, if you haven't read that part, or if you are not very sure on that part, definitely this can have a 3 or 4 diagnosis. But in this scenario, if you ask what is your probable diagnosis, they'll only consider one diagnosis. And one diagnosis that might not be only a single one. Impingement syndrome, rotator cuff injury, adhesive capsulitis. There might be a 3 or 4 or maybe 2 or 3 diagnoses that they might consider even if you write that. Just a rotator cuff injury, rotator cuff involvement, diagnosis. Maybe they might include 2 or 3 diagnoses that might look like your scenario. Okay, but they won't give you marks. Okay, list a few conditions which can precipitate this kind of injury. Okay, that is okay. Apart from physical examination, what imaging will help you? Okay, these all are very specific questions. What imaging? You should write that specific imaging that will help in the diagnosis. Other than that, what is the imaging that will help in diagnosis?
MRI shoulder.
MRI shoulder. Okay. What are your treatment options for these patients? Okay. What are your treatment options? A question like that might appear very non-specific. It's like we writing complications of a drug, nausea, vomiting, diarrhea, treatment option analgesia, sling, rest. We might be thinking 3 or 4 treatment options, but they'll be specifically evaluating for a few points. If you are not writing those points, they won't give you marks. Even though those questions which might appear less specific will also have very specific answers. Okay, about part B comparatively is a tough one compared to part A. Part A is definitely you have multiple choices. The chances of you going wrong is very less. So part B, you have to be very specific, and you have to give the answer that they expect from you. So that is a bit difficult. But you have a lot of references, guides, online guides, and all things like that, which will help you. And they will be listing out points based on previous question papers and based on the answers. And the thing is, they will mark your each and every answer based on how well you have written that question. If I have written this question, this is as you know, there will be 60 questions for 3 marks. So one question will carry 3 marks. Each part will be having, they will at the end of your exam, when the results come out, they will give you the marks and how much marks you have scored for each question and each sub question. So you will be able to understand how well you have scored for your each questions and each answer. So in that way, you can say either your answer is right or no, or if your answer is partial or completely written. So that will help in improving your answers. Based on that, there are a lot of online forums. There are multiple books based on FRCOM Part B on helping you to how to write or how to improve your answering skills in Part B. Looking into that is mandatory. Looking into that will definitely help you in giving better answers to specific questions. Other than that, I think Nadia has mentioned almost everything regarding dislocation and rotator cuff injuries. Rotator cuff injuries anatomy parno. Yeah, I think that's it. Baki a bit more, I think we'll cover in Part C in the practical thing. Okay. Just give me 2 minutes to just set the thing up. Okay. Okay.
Okay, sir.
Hello.
Yes, sir.
Yeah. Ernest is on duty. So we'll just catch hold of her. So I think you guys can see that.
Yes, sir. Yes, sir.
So the scenario is this is a 70-year-old male. 70-year-old male presenting to ED with complaints of right shoulder pain for a duration of 6 months. Examine his shoulder and explain your diagnosis and management plan. Okay. So, one second. So this is a 70-year-old male presenting to ED with complaints of shoulder pain for past 6 months. So, Dr. Vernas will be examining him and giving him the management plans, further management plans. We have 7 minutes. Explain your diagnosis and management plan. Your time starts now.
എന്താണ് ബുദ്ധിമുട്ടുള്ളത്?
ഈ ഷോൾഡർ നല്ല പെയിൻ.
എന്തെങ്കിലും ചെയ്യുമ്പോഴാണോ നിർത്തിയിരിക്കുമ്പോൾ തന്നെ വേദന ഉണ്ടോ?
എനിക്ക് ഒന്നും അങ്ങോട്ട് ചെയ്യാൻ പറ്റില്ല. കൈ അങ്ങോട്ട് പൊക്കാൻ പറ്റില്ല, ഒന്ന് മുടിയിടാനായിട്ട് പറ്റില്ല, ഒന്നും അങ്ങ് എടുക്കാനോ. എപ്പോഴും പെയിൻ. ഇപ്പൊ തന്നെ ഒരു കുറഞ്ഞ 6 മാസമായി ഇങ്ങനെ വേദന വരുന്നു.
എനിക്ക് അച്ഛനെ ഒന്ന് പരിശോധിക്കാം. കാരണം എന്താണെന്ന് വെച്ചാൽ നമുക്കൊരു ഷോർട്ട് കൂട്ടത്തിലൊന്നും പരിശോധിക്കുന്നത്. ഞാൻ പരിശോധിക്കുമ്പോൾ എന്തെങ്കിലും വേദനയോ എന്തെങ്കിലും ഒരു ബുദ്ധിമുട്ടുണ്ടെങ്കിൽ എന്നെ ഒന്ന് പറയണം. അച്ഛന് പറയാൻ പറ്റുമോ? ഞാൻ വിളിച്ചത് നേരിരിക്കാൻ പറ്റും. നേരിരുന്ന് the anterior aspect of the ring is calm, the ring bruises, even that ring. നേരെ നോക്കിയാൽ മതി. നേരെ നോക്കിയാൽ examine from the right side. On the right side is the really bruises, swelling or scar that can be seen.
You can just examine. I will give the time. Safe person.
അച്ഛൻ ഞാനൊന്ന് തൊട്ട് നോക്കുന്നുണ്ട്. ഏതെങ്കിലും സമയത്ത് അച്ഛനൊരു വേദന വന്നാൽ എൻ്റെ അടുത്ത് പറഞ്ഞാൽ മതി. നമുക്കപ്പം ഞാൻ നിർത്തും. Checking the temperature, any temperature difference in the right shoulder and palpating. തൊടുമ്പോൾ എന്തെങ്കിലും വേദന ഉണ്ടോ? ഇങ്ങനെ അമർത്തി നോക്കുമ്പോൾ എന്തെങ്കിലും വേദന ഉണ്ടോ? ശരി. നിങ്ങൾ ഭയങ്കര വേദനിക്കുന്നുണ്ടോ? ഒന്നെന്ന് പറഞ്ഞാൽ തീരെ വേദനയില്ല, 10 എന്ന് പറഞ്ഞാൽ സഹിക്കാൻ പറ്റാത്ത വേദന. 1 മുതൽ 10 വരെ അച്ഛൻ ഇങ്ങനെ വേദനകൾ കൂടിക്കൊണ്ട് പോവാണ്. ഞാനിവിടെ അമർത്തുമ്പോൾ അച്ഛൻ എത്ര വേദന ഉണ്ട്? വെറുതെ കൈ വെക്കുമ്പോൾ അച്ഛൻ എത്ര വേദന ഉണ്ട്? ചിലപ്പോൾ തൊടാതിരിക്കുമ്പോൾ അവിടെ വേദന ഉണ്ടോ? അച്ഛൻ സ്വന്തം കൈ ഞാൻ ചെയ്യുന്ന മാതിരി ഈ കൈ ഇങ്ങനെ മേലേക്ക് ഇങ്ങനെ പൊട്ടിച്ച് അങ്ങനെ പൊക്കുമ്പോൾ എന്തെങ്കിലും വേദന വരുന്നുണ്ടോ? എവിടെ വരെയാണ് പൊക്കും? അവിടെ പൊക്കുമ്പോഴാണ് വേദന. ശരി. ഞാൻ മെല്ലെ കൈയും ഇതീന്ന് ഇങ്ങനെ ആക്കുന്ന പിന്നിലേക്ക് ഇങ്ങനെ ആക്കിയിട്ട് അങ്ങനെ ആക്കാൻ പറ്റുന്നുണ്ടോ? വേദന. ശരി. ഈ സൈഡിൽ കൂടി അച്ഛൻ ഞാൻ ആക്കുന്ന മാതിരി ഇങ്ങനെ ഒന്ന് മേലേക്ക് ഇങ്ങനെ പൊക്കിട്ട് അങ്ങനെ പൊക്കുമ്പോൾ വേദന ഉണ്ടോ?
ഇവിടെ എത്തുമ്പോൾ
വേദന. ശരി. ഇനി അച്ഛൻ ഇങ്ങനെ കൈ ഇങ്ങനെ ഒന്ന് ആക്കിയിട്ട് ഞാൻ ആക്കുന്ന മാതിരി വേദനിക്കുന്നുണ്ടോ? അവിടെ വേദന. ഇനി കൈ ഇങ്ങനെ അടുപ്പിച്ച് വെച്ച് ശരീരത്തിനോട് അടുപ്പിച്ച് വെച്ചിട്ട് കൈ ഇങ്ങനെ ആക്കിയിട്ട് അപ്പം വേദന ഉണ്ടോ? ഒരു ടൈറ്റ് ഫീൽ ഉണ്ട്. എവിടെ എത്തുമ്പോഴാണ് ആ ടൈറ്റ് ഫീൽ അച്ഛന് തോന്നുന്നത്? ഇവിടെ എത്തുമ്പോൾ അച്ഛന് അനക്കാൻ ഒരു ബുദ്ധിമുട്ടുണ്ട്. ഇങ്ങനെ ആക്കുമ്പോൾ ഇങ്ങനെ അടുപ്പിച്ച് ഇങ്ങനെ അടുപ്പിച്ച് ഞാൻ അച്ഛൻ്റെ കൈ പിടിച്ച് ചെയ്യാൻ പോവാണ്. അച്ഛന് വേദന തുടങ്ങും. വേദനയ്ക്കാണെങ്കിൽ പറയാം. അതേമാതിരി എന്തെങ്കിലും ഡിസ്കംഫർട്ട് ഉണ്ടെങ്കിൽ പറയൂ കേട്ടോ. കൈ ലൂസായിട്ട് വെച്ചോ. വേദനയുണ്ട്. ശരി. വേദനയുണ്ടോ? അച്ഛനായിട്ട് എൻ്റെ കൈയൊന്നും മേളിലേക്ക് ഇങ്ങനെ പൊട്ടിച്ച് സൈഡിൽ കൂടി സൈഡിൽ വേദന. ശരി. അച്ഛൻ ഒന്ന് കൈങ്ങനെ പൊട്ടിച്ച് കുറച്ച് മുമ്പോട്ട് വേദനയുണ്ടോ? എപ്പോഴെങ്കിലും നമുക്ക് ഇവിടെ ഇടിച്ചു പോകുമോ? അതോ എന്തെങ്കിലും സർജറി മാതിരി
സർജറി ഒന്നും ചെയ്തിട്ടില്ല. ഇങ്ങനെ വേദന ഞാൻ പറഞ്ഞില്ലേ 6 മാസമായിട്ട് തുടങ്ങി. ഇടയ്ക്കിടയ്ക്ക് ഞാൻ കൊണ്ട് കാണിക്കുമ്പോഴൊക്കെ കുറെ ഗുളികളോട് വരും. എന്തിനാ കഴിഞ്ഞു കഴിക്കും, കുറച്ച് മാറും, വീണ്ടും വേദന.
എന്തെങ്കിലും എക്സ്റേ
കാണുന്ന എല്ലാ ഹോസ്പിറ്റലും എക്സ്റേ എഴുതണം. അച്ഛൻ ഏതെങ്കിലും എല്ലിന്റെ ഏതെങ്കിലും ഡോക്ടറെ കാണിച്ചിട്ടുണ്ടോ?
എന്തായാലും ഡോക്ടേഴ്സ് അടുത്ത് പറഞ്ഞത് കാണിച്ചപ്പോൾ അതിനെന്തെങ്കിലും മരുന്ന് കഴിക്കുന്നുണ്ട്? എന്തിനാണ് മരുന്ന് കഴിക്കുന്നത്? റെഗുലർ ആയിട്ട് എന്തെങ്കിലും മരുന്ന് കഴിഞ്ഞ എന്തെങ്കിലും പരിപ്പ് വിരലിന് അങ്ങോട്ടേക്ക് ഒരു പരിപ്പ് അങ്ങനെ എന്തെങ്കിലും തോന്നാറുണ്ടോ? താങ്ക് യു. അച്ഛൻ്റെ പഴയ എക്സ്റേസ് എന്തായാലും നമുക്ക് നോക്കണം. ആ സമയത്ത് എക്സ്റേ എടുത്തത് അപ്പൊ നമുക്ക് ഒന്നും കൂടി എക്സ്റേ എടുത്തിട്ട് ആ പഴയ എക്സ്റേ വെച്ചിട്ട് എന്തെങ്കിലും ചേഞ്ചസ് ഉണ്ടോ എന്ന് നോക്കാം. ഇപ്പം വളരെ അധികം ഒരു വേദന ഉണ്ടെങ്കിൽ തൽക്കാലത്തേക്ക് ആ വേദന കുറയാൻ വേണ്ടിയിട്ട് നമുക്ക് നല്ലൊരു മരുന്ന് തരാം. ഇപ്പം വേദന ഉണ്ടോ? വേദന നമ്മളെന്ന് വെച്ചാൽ ഇപ്പം എനിക്ക് ഇഞ്ചക്ഷൻ ചെയ്ത് കുറഞ്ഞത് വീണ്ടും വേദനയുണ്ട്. അപ്പൊ അങ്ങനെയാണെങ്കിൽ നമുക്ക് ഒരു എക്സ്റേ എടുത്ത് നോക്കണം. അത് കഴിഞ്ഞിട്ട് ആ എക്സ്റേ വെച്ചിട്ട് വേദനയും പറഞ്ഞത് പൊസിഷനിൽ വെക്കുമ്പോഴാണ് കൂടുന്നത്. അതനുസരിച്ച് നമുക്ക് വേണ്ടത് ഓർത്തോന്റെ ഡോക്ടറായിട്ട് സംസാരിച്ച് നമുക്ക് ആ രീതിയിൽ ചെയ്യാം. ചെയ്താൽ കുറച്ച് ബ്ലഡ് ടെസ്റ്റ് എടുക്കാനുണ്ട്.
I think all of you had seen awareness perform. Now, okay. So now we'll see what all things has to be examined while examining a shoulder. Okay. I'll just put up the presentation. By the way, those who are in here, Bindya, Nadia, John, Anjana, so on and on. How did she perform?
Sir, there are good points as well as few things what she has missed.
Okay. Appo good points first പറയാം.
Good points. She was very calm. ഒരു hurry burry ഒന്നും ഉണ്ടായിരുന്നില്ല. She was very polite with the patient. She asked for the pain score properly. She assessed the pain score. പിന്നെ one more thing was that correct ആയിട്ട് right side of the patient നന്നായിട്ടായിരുന്നു examination ഒക്കെ perform ചെയ്തത്. She was listening to the patient properly and there was a good rapport between the doctor and the patient. പിന്നെ communication was very good with the patient. അതാണ് good points.
വേറെ ആർക്കെങ്കിലും എന്തെങ്കിലും ഗുഡ് പോയിന്റ്സ് പറയണ്ട? Okay. What did she miss?
I think introduction, I don't know whether she has done. It was not clear for me.
Okay.
Self-introduction. Then thing is, she didn't confirm the patient. Is this you? Like name, idano. Inne patient aano nu confirm cheyanam. The third thing is, hand rub was not used. Universal precaution glove was not used. Then pain allergy history ഒന്നും ചോദിച്ചില്ല. പിന്നെ പെയിൻ ഓഫർ ചെയ്യണോ, ഡു യു വാണ്ട് സം അനാൽജസിക് എന്നുള്ളൊരു ക്വസ്റ്റ്യൻ വന്നില്ല. പിന്നെ അറ്റ് ദ എൻഡ് താങ്കിങ് വാസ് നോട്ട് ഡൺ ആഫ്റ്റർ എക്സാമിനേഷൻ. താങ്ക് യു പറഞ്ഞില്ല പേഷ്യന്റ് അടുത്ത് ഫോർ കോപ്പറേറ്റിംഗ് ഫോർ ദ എക്സാമിനേഷൻ. ആൻഡ് ഫ്യൂച്ചർ പ്ലാൻസ് ഇൻവെസ്റ്റിഗേഷന്റെ കാര്യം മാത്രമേ പറഞ്ഞുള്ളൂ. ഡിഫറൻഷ്യൽസ് ആൻഡ് വാട്ട് വുഡ് ബി ദ പ്ലാൻ എന്നുള്ള കാര്യം പറഞ്ഞില്ല.
വേറെ ആർക്കെങ്കിലും ആഡ് ചെയ്യണ്ട? വേറെ ആർക്കെങ്കിലും എന്തെങ്കിലും ആഡ് ചെയ്യണ്ട? Okay. Okay. as you said, she had covered many things. There are some misses, so we'll see what all things she has missed. Okay, is the screen visible?
Yes, sir.
Yeah. Okay. So in the question it was a female, I changed it to a male. So the key points that should have been that should be included were, you can't see. Okay, thank you. Yeah. Introduce self to patient appropriately. Introduction was done.
Yes.
Confirm patient's identity. That was not done. So,
Yeah.
yeah. Patient age okay. Explain reason for examination and obtain consent. I think that was done. Enquires regarding presence of pain and offer analgesia if needed. You asked it while you were examining. While you were examining, she asked if there is any pain, we'll stop it in the middle. Okay. Confirm history. And ask for history. Clean hands appropriately. That was not done. Okay. Adequate exposure of both shoulders. That was there. Perform adequate inspection from front, side, and back, and also axilla. I think axilla was not examined, but she examined it from front, side, and back. Always, I think, when looking for a shoulder joint, you ask the patient to stand and then look around the patient. Examine for winging of scapula. That was not done. Palpate systematically local temperature and also all structures, including the clavicular, sternoclavicular joint, the entire clavicle, acromion, coracoid, humeral head, biceps tendon, scapula, spinoscapula. Okay. Check for active movements. Okay. Check scapulothoracic coordination from the back. The thing is, you will have to ask the patient to abduct the arm and see if how was the scapulothoracic coordination, because abduction requires both glenohumeral and also scapulothoracic movement. So that should be done. Check internal and external rotation. Okay. Stabilize scapula and check passive movements of glenohumeral joint. So you'll have to stabilize the scapula and ask the patient to move the joint. Okay. About that is initially just the introduction part, and next is the general part. In general inspection, general palpation, and examination of activities. Next is looking for power of flexors, extensors, abductors. So how was the flexion of shoulder joint? How can you examine for flexion of joint? Anyway.
Actually, when we are asking, we'll ask the patient to. So actively, we'll ask the patient to raise the hands till he can fall to the ceiling.
Okay. What is extension?
And extension will be asking the patient to keep his hands back as far as possible.
That's extension. Shoulder joint in extension.
Extension arm stretch out
external rotation.
External rotation is
okay.
And this was shown as the internal rotation.
Adduction, abduction.
Abduction was this, and adduction was this.
Okay. Shoulder. The plane of shoulder joint is ഒരു oblique ആണ്. അത് it is not flat. അത് കുറച്ച് oblique ആണ്. അപ്പോൾ flexion is, I think you guys can see me അല്ലേ? കാണാൻ പറ്റുന്നുണ്ട് എന്നെ?
Yes.
Yes, sir. Yes, sir.
Okay. So this is flexion and this is extension. So this is the plane. ഇതല്ല plane. ഇതാണ് plane. So this is ഒരു and flexion. The plane is ഒരു 30 degrees slant ഉണ്ട്. അപ്പോൾ this is the flexion and this is the extension. Abduction, adduction, as you said, is correct. External rotation, internal rotation. Yeah. Okay. So assess the power of flexors, extensor, abductors, and adductors, and assess power of all rotator cuff muscles specifically. But you are just tested for EMCON test. Can you just show how you check what all things to be done?
First, we'll ask the patient to flex his hands
Okay.
about 90 degrees and then slowly bring it 30 degrees forward.
Okay.
And ask with the thumb facing down. And we'll tell the patient that we are going to try and push him down. The patient would resist it.
Okay, great. Okay, what does that suggest?
That it could be a impingement of the supraspinatus.
Okay, great. For impingement of a supraspinatus. One more thing for the other test for
Painful test.
okay, painful.
We ask the patient to do the we'll do the abduction for the patient, and then he has to actively slowly bring it down. So usually when there will be a supraspinatus impingement around 60 to 90 degree at the patient.
What you said is drop test, and the 60 to 90 thing is painful arc. Drop test is for supraspinatus. Painful arc is 45 to 90 degree. At that point, there will be pain. That is painful arc syndrome. That is a bit different. And also, so EMCON test and drop test for supraspinatus. External rotation. Ask the patient, how do you do external rotation?
So ask the patient to keep his hands nearby.
Yeah.
Like this, and we keep a hand and we'll ask the patient to press against our hand. So if there's any...
You are resisting the external rotation. So external rotation will test for infraspinatus and teres minor. And lift off test. Just stand.
We'll ask the patient to keep his hands towards the back as far as he can. Then we keep our hand next to his palm and we'll ask the patient to press against our palm while we give resistance.
You're asking the patient to lift the hand off his back. So that will test for subscapularis. Yeah. Next thing is testing for impingement. Mears test. So, for this test, you will flex and abduct the arm and also rotate the arm. So during that time, he will have pain in the angular or lateral part.
So this is the one that we check for the acromial joint.
AC joint, you can check, but at that time you won't be externally rotating. So if you if you abduct and flex the arm, then externally rotate, and during that time, if the patient has pain, that is suggestive of impingement syndrome. So you are decreasing the space between the acromial joint and the humerus, and you are making the space smaller and then impinging the supraspinatus. Acromioclavicular joint pathology, even if you don't externally rotate, there will be. So if there is pain in just lifting up and that is flexing and abducting, if there is pain, that might be acromioclavicular joint-ish pathology. But if there is pain while externally rotating, then you are actually impeaching that subscapularis, not supraspinatus. Supraspinatus. So that is a sign of impingement syndrome. Okay. Next is checking for instability. You should be checking for instability of the joint. See if the how stable the joint is. One thing is sulcus test. You give a downward traction and look for the glenohumeral joint. If there is a significant gap between the acromion and the humeral head, that suggests that there might be a inferior dislocation. There is a possibility for inferior dislocation. Okay, there's a possibility for inferior dislocation. Next thing is an apprehension test. So that is for anterior dislocation. The patient hand is held and that is in abduction, and you are trying to push the hand out of the joint. Okay. During that time, if the patient gets apprehended, patient feels or says that he feels his joint is getting out of his capsule, that suggests that there is an anterior joint laxity. That can be a sign of an anterior dislocation. Okay. Next thing is examine the neurovascular status of the limb. Okay. And the other thing is comments on the need to examine the joint above and below. So for every joint, you should be examining the joint above and below. You should thank the patient and offer help to redress, correctly identify clinical signs, correctly states diagnosis. The diagnosis was not made. This was a impingement syndrome. He was having pain on your EMCON test. He was having pain. Local tenderness was there. He was having a history for past 6 months. And when you had asked specifically, I had instructed him to say that pain is more during night, and also pain is more during overhead activities, unable to comb and things like that. Okay. Correctly states the diagnosis, describe appropriate management plan. That was also not complete. And ask if patient has any questions. So how much mark will you give for this, for your examiner? How much mark will, as a patient, will you give for this exam?
Out of 10?
Out of 10. The mark will be based on how she has approached you, what all things she has explained to you, how she has examined you. Was she careful enough? Was she considering your pain, your privacy, and how well you were explained about your disease, how satisfied you were after your visit to the doctor.
7.
7. Okay. So that is the mark from the patient. Okay. Thank you. Asif Naru, big thanks. You are a nice patient. Okay. Yeah. So anything more to add?
Sulcus test എന്ന് പറയോ?
Sulcus test നമ്മൾ പേഷ്യന്റിന് ഡൗൺവേർഡ് ട്രാക്ഷൻ കൊടുക്കുക കയ്യിൽ, എന്നിട്ട് ഈ ജോയിന്റ് എക്സാമിൻ ചെയ്യുക. അപ്പൊ ആ സിഗ്നിഫിക്കന്റ് ഗ്യാപ്പ് വരുന്നുണ്ടോ എന്നുള്ളത് നോക്കുക.
ഓക്കെ ഓക്കെ
ഓക്കെ.
ഗ്യാപ്പാണ് നമ്മൾ നോക്കുന്നല്ലേ, നോട്ട് ദ പെയിൻ.
പെയിൻ അല്ല, ഡിസ്ലൊക്കേഷൻ കൂടുതലായിട്ട് നമുക്ക് ചെയ്യാൻ പറ്റുന്നുണ്ടോ, ഡിസ്ലൊക്കേറ്റ് ചെയ്യാൻ പറ്റുന്നുണ്ടോ എന്നുള്ളതാണ്.
ഓക്കെ, താങ്ക് യു സർ.
I think she did fairly well, though she couldn't get into a specific line. E segment 75% of the mark is for clinical examination. Only 25% is for communication. It depends on how well you look or examine the joint. So first, inspect the joint, inspect anteriorly, laterally, including the axilla, and also posteriorly after undressing the patient. Then you palpate the entire joint, front and back, look for any joint swelling, and then after you ask the patient to move the joint actively, look all range of movement, note if there is any pain or this restriction of range of movement while you move that joint. After that, you look for winging of scapula specifically to look for any nerve damage. Then you assess the power. After active movements, you assess the power of all joints, all abductors, adductors, and things like that. And then specifically you look for muscles of rotator cuff. That is supraspinatus, you look for MT can test and also drop test. Subscapularis lift off in external rotation for the other two muscles, teres minor and infraspinatus. Also, the next pathology that can affect is a dislocation. So look for the sulcus test and apprehension test. Okay, so in that way your examination is fairly complete. Okay, all joints and regarding all musculoskeletal injuries and all, there will be lot of other tests also. The apprehension test and there is, I think, apprehension impingement syndrome, the test that we mentioned. There is another test which is also somewhat like the test that we have mentioned, impingement syndrome. There will be a lot number of mild variations of these tests, but just know one or two of them. If you are asked to do, just know one or maximum two of those tests. But in every joint, there will be multiple named tests and multiple named maneuvers for examining the joint. So main joints would be shoulder, knee. Yeah, that's it. Mainly shoulder and knee. Other joints are also there, but the number of tests, named tests and maneuvers will be less in other joints. So shoulder and knee is very important. And also to an extent pelvis or femur. Know the names of a few of them, know how it is being tested, and then do it. I think that's
Sir,
it.
neurovascular status sensations ഒക്കെ നോക്കണമല്ലേ?
Sensations grossly നോക്കിയാൽ മതി. അതായത് dermatomes നോക്കാം. How is the dermatome of upper limb?
C5.
C5 തൊട്ട് C6, C7, C8, T1, T2.
Okay, അത് മാത്രം നോക്കിയാൽ മതി.
Mainly C4 എന്ന് തുടങ്ങാം. C3, C4 എന്ന് തുടങ്ങാം. C5 and the other dermatomes also.
Okay.
പിന്നെ you can assess the
adjacent
pulse.
joints നെ പറ്റി നമ്മൾ മെൻഷൻ ചെയ്യണോ? Adjacent joints നെ പറ്റി.
Joint above and joint below should also be assessed. അപ്പോൾ നമുക്ക് താഴേക്ക് ഹ്യൂമറസ് എൽബോ ജോയിന്റ് ഇവിടെ നെക്കും കൂടി നെക്കിന്റെ മൂവ്മെന്റും കാര്യങ്ങളും കൂടി ഒന്ന് അസസ് ചെയ്യണം. അപ്പോൾ ഏത് ജോയിന്റ് ആണെച്ചാലും ജോയിന്റ് above and below should also be examined.
പിന്നെ സാറ് പറഞ്ഞ പോലെ സൾക്കസ് ടെസ്റ്റ് പോലെ തന്നെയാണോ അപ്രിഹെൻഷൻ ടെസ്റ്റിലും ഈ ഗ്യാപ്പ് ആണോ നമ്മൾ നോക്കുന്നത്, അതോ പെയിൻ ആണോ നോക്കുന്നത്?
പെയിൻ അല്ല, പെയിനെക്കാട്ടിലും പേഷ്യന്റ് പറയും ജോയിന്റിൽ നിന്ന് പോകുന്നുണ്ട് അല്ലെങ്കിൽ ജോയിന്റിൽ നിന്ന് ഇറങ്ങുന്നുണ്ട് എന്നുള്ളത് പറയും. അപ്രിഹെൻഷൻ ടെസ്റ്റ് ഹാസ് എ വെരി ഹൈ സെൻസിറ്റിവിറ്റി ആൻഡ് സ്പെസിഫിസിറ്റി. അപ്പോൾ നമ്മൾ ആ പൊസിഷനിൽ വെച്ചിട്ട് if you are pushing, the patient will feel that the joint, the humerus is getting out. അല്ലെങ്കിൽ patient will wince. That is not due to pain, പക്ഷേ ഡ്യൂ ടു ആ ഒരു അപ്രിഹെൻഷൻ. അപ്പോൾ സ്പെസിഫിക്കലി ചോദിക്കണം, വേദനയാണോ അതോ ജോയിന്റ് വിട്ടുപോരും എന്നുള്ളതാണോ എന്നുള്ളത് സ്പെസിഫിക്കലി ചോദിക്കണം. പെയിൻ ഡസൻറ്റ് ഹാവ് മച്ച് ഓഫ് എ വാല്യൂ. ആ ഒരു ഫീലിംഗ് ഓഫ് ദാറ്റ് ജോയിന്റ് അല്ലെങ്കിൽ ദാറ്റ് ബോൺ കമ്മിങ് ഔട്ട് ഓഫ് ദി ജോയിന്റ് ഇസ് ദി ഡയഗ്നോസ്റ്റിക് or that is more important.
Okay, sir. Thank you, sir.
വേറെ എന്തെങ്കിലും ക്വസ്റ്റ്യൻസ്, എനിത്തിങ് മോർ ടു ആഡ്? ഓക്കെ, ഐ തിങ്ക് ദാറ്റ്സ് ഇറ്റ്. വേറെ ഒന്നും ഇല്ലെങ്കിൽ വേണു സാർ എന്തെങ്കിലും ആഡ് ചെയ്യണ്ടോ?
ഇല്ല, നന്നായിട്ട് ഇറ്റ് ഈസ് ഓൾ ഹാപ്പൻ വെരി വെൽ. അതെല്ലാം വളരെ ഒരു ടീച്ചിങ് സെഷൻ പോലെ തന്നെ